In the previous videos, we have covered airway topicalization, nerve blocks, and sedation for awake fiberoptic intubation. In this video, we will focus on the key instrument at the heart of this procedure, the fiberscope. A fiberscope is a handheld device made of fine glass fibers bundled together. These fibers carry light down to the tip to illuminate the airway and bring the reflected image back so the operator can see the structures ahead. In modern practice, the fiberscope is connected to a video system, projecting the image onto a screen for a clear, enlarged view that the whole team can see. There are three important parts of a fiberscope that we need to know to use it effectively: the eyepiece or camera, the angulation lever, and the working and suction channels. The eyepiece of the fiberoptic scope is the part through which the operator directly views the image carried back by the fiber bundles. It magnifies and focuses the airway structures, allowing clear visualization during intubation. Focusing is done using the diopter adjustment ring around the eyepiece. While modern scopes usually connect to a video camera and monitor, the eyepiece is still important as a reliable backup if the video system fails. Next, the angulation lever is located on the back of the handle and is operated with the thumb. When the lever is pushed down, the tip of the fiberscope bends upward, and when the lever is pulled up, the tip bends downward. This mechanism allows precise control of the tip, which is crucial for guiding the scope smoothly around the curves of the airway. It's important to note that the angulation lever only provides up and down movement of the tip. True side-to-side or lateral movement is achieved by rotating the entire scope by hand. Finally, the working and suction channels run along the scope and both open at the distal tip. Through these openings, we can suction secretions, deliver oxygen, spray topical anesthetics, or even pass instruments like catheters and guide wires while the scope remains in place. In smaller scopes, the two channels may be combined into a single multipurpose channel. Apart from the three main structures we already discussed, another key part of the fiberscope is the cord. This is the long, flexible shaft that connects the handle to the distal tip, and it's the part that actually enters the patient's airway. A larger diameter cord means more bundles of fibers inside, which improves the image quality. It also allows for bigger working channels, which makes suction and instrument use more effective. But when we use the scope for intubation, the scope has to fit comfortably into the airway, and it must also allow an endotracheal tube to be railroaded over it. That's why we match the external diameter of the scope with the internal diameter of the tube. As a rule of thumb, the endotracheal tube should be at least one size larger than the fiberscope. For example, a 5 mm tube will fit over a 4 mm scope. In adults, the fiberscopes we commonly use are between 4.5 and 6.5 mm in diameter. To successfully intubate with a fiberscope, you need to be familiar with the basic scope movements. The good news is that there are only three main movements: handle rotation, tip flexion, and cord insertion or retraction. Handle rotation means rotating the handle to rotate the tip, which is mainly achieved by flexing and extending the wrist rather. Tip flexion is controlled by the angulation lever, where pulling it down makes the tip go up and pulling it up makes the tip go down. Cord insertion or retraction is done by the other hand, which gently pushes or pulls the cord to advance or withdraw the scope. By combining these three movements, we can guide the scope smoothly, even around curves. Successful maneuvering of the endoscope relies on the three-step rule: stop, center, and move. Once the scope has entered the airway, it is important to stop and identify the target before proceeding. After identifying the target, it should be brought to the center of the field of view using the three basic scope movements, and the scope should not be advanced until this is achieved. Only when the target is centered should the scope be advanced, and if the target moves out of the center, the process of stopping, centering, and moving should be repeated. Several tips can make scope handling easier. The endoscope should be kept straight to avoid loops, since loops reduce tip control. Adjusting the operator's position or bed height may help. All movements must come from the wrist, not the shoulder, as shoulder use reduces control and promotes loops. There are several videos on YouTube demonstrating how to handle and maneuver a fiberscope. These provide a more complete visual guide to its use than can be covered in this video, so it's highly recommended to refer to them for practical demonstrations.